Okay, we'll start the meeting. Good evening, everyone. A warm welcome to all of you who have joined us today for this important and insightful webinar conducted by AMR Declaration Trust. Managing Trustee is Dr. Abdul Ghafoor, Consultant Infectious Diseases, Apollo Cancer Center. The AMR Declaration Trust is a public charitable trust founded on the principles of Chennai Declaration Document and Initiative. Our primary mission is to stimulate discussion, inspire action, and explore innovative solutions to address the global challenges of antimicrobial resistance. We'd also like to take a moment to thank our sponsors, Viatris and Pfizer, for their continued support in helping us conduct these educational sessions without any registration fees to the attendees. So today's webinar focuses on a topic of a critical importance, antimicrobial stewardship in ICU setting. This session will address three key subtopics. First topic is antimicrobial stewardship program in ICU settings, which will be presented by Dr. Nipa Singh, Professor of Microbiology in Kalinga Institute of Medical Sciences, Bhubaneswar. And our second topic is on monitoring of antimicrobial stewardship in ICU, will be presented by Dr. Smritila Shaho, Consultant Microbiologist and Infection Control Officer at Ashwini Groups of Hospital. And our third topic is on challenges in implementing antimicrobial stewardship in ICU setting, which will be discussed by Dr. Amit Raha Panigrahi, Assistant Professor of Critical Care Medicines at Kalinga Institute of Medical Sciences, Bhubaneswar. So we are honored to have these distinguished speakers with us today. To begin the session, I now invite our first speaker, Dr. Nipa Singh, to speak our antimicrobial stewardship program in ICU setting. She holds a key leadership role, including member secretary and infection control officer of HICC at Kalinga Institute of Medical Sciences for the past 5 years. Dr. Nipa is also an active member of Antimicrobial Stewardship Program Committee and the Quality and Safety Committee of our hospital. Additionally, she is a certified NABH entry-level accessor. Over to you, Dr. Nipa. Please can present the meeting.
Good evening, everyone. This is Dr. Nipa, and I'm very glad for the short and brief and thoughtful introduction given by Afreen. I am grateful to the AMR Declaration Trust for giving me this opportunity to speak on a very pertinent topic in the healthcare sector setup. Now I'll be sharing my PPT. Okay, once again, welcome all the participants and the speakers. And I'll be introducing the topic of AMS or the Antimicrobial Stewardship Program in the ICU setting. Now, first, I will be going through or walking you through what are the main components of the AMSP program in the ICU setting, followed by Dr. Smriti Lata, who will be speaking on the monitoring of the program in the ICU setting, and Dr. Amit will be speaking on the challenges of implementing this in the ICU. Now, why did we, before I begin this, I would like to say, why did we choose this topic, and what is the relevance of this topic in today's healthcare setup? According to WHO, it estimates, it says that as of now, as of 2021, the previous estimates said that around 1 to 1.4 million people died of AMR. But if this is unchecked and we do not do any, action which would stop this spread of AMR, it is estimated that directly around 10 million deaths would occur by the end of 2050 due to AMR. Now, this is actually a direct projection of 10 million deaths. But you see, indirectly, AMR would contribute to many more deaths. Now, we all know, I hope that all the participants, I assume that they are from the healthcare sector, since they have registered for this program. So we know the ongoings, I mean, the how it works in a hospital setup. You see, directly we never say AMR has caused a death. So the cause of death is given as sepsis. It is given as some antecedent cause which the patient was suffering from. But you see, we as doctors, healthcare professionals, we know that why the patient could not recover from sepsis, because we did not have the adequate arsenal to combat the sepsis. That is, the sepsis was caused by such an organism which could not be cured by the antibiotics which are in our pipeline as of now. Now, herein comes the relevance of the antimicrobial stewardship. Now, this AMR, as we know, has developed because of the rampant, indiscriminate use, irrational use, suboptimal use. We could go on and on regarding the uh, causes of the AMR. Now, one rational way of stopping the spread of AMR is the antimicrobial stewardship. And this although it is quite relevant in all the sectors, be it in all the units of the healthcare sector, be it a OPD, IPT, or an intensive care unit, but it is all the more important to implement this program in the ICU, because herein we see the majority or the huge chunk of the antibiotics which we use in a healthcare sector are due to the ICU usage. Most of the antibiotics, or the high-end antibiotics, or the broad spectrum antibiotics, they are being used primarily in the ICU setup. Now, so that is why this uh, topic carries a lot of importance. And me being a, I have been associated with the HICC committee since the last 5 years. So this is a topic which I think the information should be disseminated not only to the healthcare sector but also to the general population. Now we know that there was a COVID pandemic. Now it was declared that it was a pandemic, but this is a silent pandemic which is going on. And this is nowhere the general public is aware that this is a pandemic which is going on. Now, my talk will be a brief outline on what topics I would be speaking on: the importance of AMR, like I have already said, the components of AMR, the diagnostic stewardship, which is very close to my heart, being a microbiologist, the interventions of the AMS, which we should be doing in the ICU, and the monitoring, although the monitoring will be taken up more in detail by Dr. Smrutilata. As I already said, that there is a high antibiotic use in the ICU setup, because there is the patients come to the ICU with life-threatening infections. So we use a broad spectrum antibiotic, and we use it also antimicrobial therapy to prevent opportunistic infections in the ICU, also prophylactically to prevent certain infections from occurring, because they are of a low immunity, all the patients who are admitted to the ICU. And there is increased risk of resistance, because there is high prevalence of severe infections in the ICU, and there is a rapid transmission also of the resistant bacteria. Now, this MDRO, or antimicrobial resistance due to the MDRO, has got an impact on the patient outcomes in terms of morbidity and mortality also, which leads to there is a financial burden also on the patients. And also in the ICU, it requires specialized expertise to work up on these patients. Now, what should be the key goal of a AMSP? It should be to optimize the antibiotics selection, to ensure appropriate duration, dosing, and to promote timely de-escalation. By de-escalation, I mean when we start empirically with a broad spectrum antibiotics, and then we get a culture report which suggests that a lower end not a broad spectrum, but a short spectrum antibiotic is effective, we should de-escalate. We prevent healthcare associated infections, so which could be super added by doing proper HICC measures, and then also monitoring and evaluation. So these are the attributable factors in the ICU setting. We have a high antimicrobial use in the ICU. The duration of stay of ICU patients are quite lengthy, so the length of stay is quite long. The nature of ICU organisms, due to the use of broad spectrum antibiotics, the MDROs survive in the ICU organisms. Also, one important factor is that there's an increased use of the invasive devices on the ICU patient, which facilitates the entry of the MDROs or the multi-drug resistant organisms. And besides, those who land up in the ICU, they usually have some comorbidities which accentuates their uh, primary illness. Now, these are the organisms which which are of importance in the ICU, which we normally call them as an acronym ESCAPE organisms. So ESCAPE stands for E stands for Enterobacter, and Staphylococcus, Klebsiella, Acinetobacter, uh, Pseudomonas, and Enterococcus. So when we consider West European countries, so you see there is in the blue portion, that is the other species are quite predominant. Herein we have E. coli, although we do not have that acronym in ESCAPE doesn't include E. coli, but in the Indian context and the LMIC countries, E. coli is a significant pathogen, followed by Klebsiella, Pseudomonas, and Acinetobacter. Now, this is the pattern of the microorganism in the bloodstream infection in the adult and the pediatric ICU unit. And these are the different types of, antibacterial resistance pattern. This was done by a study by Chakrabarti et al., a recent study 2 years back in a tertiary care hospital in Kolkata. So we have organisms like Klebsiella uh, and E. coli. So you can see here they are quite resistant to the cephalosporins, second, third, and fourth generation, also to the carbapenems. So you see we have almost exhausted our arsenal of antibiotics. Besides, we also have Acinetobacter and Pseudomonas, which are also becoming quite resistant to the antibiotics as of now. So what is an antimicrobial stewardship? Antimicrobial stewardship is an intervention wherein we give the right antibiotic for the right patient at the right time with the right dose and the right route, causing the least harm to the patient and the future patient. So this is what I mean, to ensure all of these as a unit or as a together, as we have to ensure that these objectives are achieved. The right antibiotic. What do you mean by the right antibiotic? We see that we first decide or uh, determine what could be the organism which infects this patient, what risk factors for resistance does this patient have. Then we choose the right antibiotic. Then, of course, this is a serious problem in the Indian ICUs. We tend to over-treat. And I think we sometimes treat colonizations also because we are fearful of missing out on infections. So to be on the safer side, we treat colonization before deciding whether it's a true infection or a colonization. Now, another thing which should be there should be some special emphasis is that the culture should be sent prior to initiating the antibiotics. So the right time for the culture should be there. So right time, once the culture is given at the right time, you could decide on a right antibiotic also. Now, right dosing. Is the antibiotic dosing appropriate for the patient's renal or hepatic function? So the normal dosing is for patients who are quite immunocompetent. But when you consider an ICU where a significant chunk of the population in the ICU have comorbidities, the dosing should be adjusted in that way. Is this patient a candidate for oral treatment? So whether the route is right or not, whether we should stop giving the IV route and change it over to oral, at what time we should stop, and least harm. So are we choosing a narrow spectrum antibiotic, or we are going on choosing a broad spectrum for all the patients in the ICU, and are we choosing the minimum duration of treatment? Now, there was a concept lesser the better, although this has not been proven as yet. There should be a fixed duration of an antibiotic, because the lesser the, there's no significant benefits or absolutely no benefits if we go on prolonging the antibiotic uh, duration without any proper indications. So these are the five or the six points, and with prudent antibacterial prescribing should be done. These are the components of AMR. So when we think of antibiotic stewardship, it is a mixture or a conglomeration of various factors, and they together make it the antibiotic stewardship successful. And what are they? First of all, it is an interdisciplinary approach. Interdisciplinary means we should have an ID doctor, a clinical microbiologist, a clinical pharmacist, a nurse with ASP training, infection control professional, and infection system specialist. So they together form the AMSP team. We should also focus on enhancing infection prevention and control, controlling the source of infection, using the short duration of antibiotics, also reassess the treatment when the cultures come, and also educating the staff. So these are the various components of the AMSP in a ICU. So the ICU physician are important drivers as well as potential solutions to the crisis of AMR. And AMSP should be considered a core competency for intensive care physicians. And this should address, we should not, it's an interdisciplinary thing. So whoever is an expert in that field, in the respective fields, they pool in together their knowledge and decide what should be the ideal treatment for the patient. So the overall antibiotic use should be improved, so thereby reducing antibiotic costs, or which should be the primary focus, de-escalation and reducing antibiotics cost. And the scope of rapid diagnostic should also be explored, and there should be a shift in emphasis to an individualized approach. That means the treatment should be individualized, but each patient should be considered as a separate patient, not a blanket coverage of an antibiotics to all patients. Now, as I said, being a microbiologist, I would say that a diagnostic stewardship is also necessary to be strengthened if we want to strengthen the antimicrobial stewardship practices. And what is this diagnostic stewardship? It is performing the right test by the right method and deliver the result at the right time. So we could have a separate session on diagnostic stewardship regarding the practical problems we face and how it could help in the AMSP. So it is actually, when a patient comes, we evaluate the patient for symptoms. Then we advise the tests, and empiric antibiotics are prescribed. And then we modify according to the culture reports. Then diagnostic stewardship is important in the sense that the specimen collection and processing should be proper. Otherwise, you get a wrong result, some contaminant, some commensal, some colonizer may grow in the cultures, which we have to distinguish. It's very difficult after we get culture reports to determine whether it's actually a colonizer or a true pathogen. So a diagnostic stewardship could go a long way in helping the antimicrobial stewardship. And antimicrobial stewardship helps in optimizing empiric antibiotics. And also we should review this prescription after a certain 48 hours. Now, benefits of diagnostic stewardship is this study by Claes Casey et al. Shows that when there were no interventions and this is the antibiotic prescribed, a patient simply comes with symptoms of UTI, you give it, you do not test for it, and then you give antibiotics. So, see, the antibiotic prescription rate is so high. Now, if we give restriction, you order a urine culture and then you go for antibiotics, the prescription of antibiotics is very limited. And all the more, it is more limited in a case where restriction of urine culture reports are there. That means you do not report all the antibiotics, you report only the ones. If in case the narrow spectrum are sensitive, you report them, and keeping in hold the broad spectrum antibiotic sensitivity. So you see, these are the benefits of diagnostic stewardship. Also, we could have improved diagnosis, like we have a white tech, back tech for blood culture, or MALDI-TOF, wherein we get rapid results of pathogens, which can help in improving the prescription pattern. Now, also the point of care tests in diagnostic stewardship should comply with the assured criteria, which that means it should be affordable, sensitive, specific, user friendly, rapid, robust, equipment free, and also delivered to end users. We have certain of the tests which we also are doing now, like ICTs for various infections, which are point of care test. We have Gene Expert, Carba NP, which are point of PCR, true PCR, which are certain point of care tests. So these point of care tests, they are done very near to the patient, doesn't take much time, and it helps in deciding the treatment of the patient. And we also it's also helpful to give the clinicians comments in our culture reports, in the microbiological reports, wherein we say that if the patient related parameters are not given to us in the requisition form, we ask for it. Specimen quality, if the patient specimen has not been collected in a proper way or not transported in a proper way, which could give erroneous results. Or we could say that site specific culture reporting, like you cannot culture certain, if you culture certain sites which are not sterile, or you culture a tip of a catheter, like we get a lot, for an example, we get lots of uh, samples of Foley's catheter tip culture, which is of no use, because it is going to be colonized by some organism after some days of insertion. Infection control advice in case MDROs are isolated. Specific organism antimicrobial agent related concepts. And the concept of BMQ, this is one point wherein it helps the clinician to choose the antibiotic. And we also predict the susceptibility related comments, like where in automated culture there are some organisms where the Vitek doesn't give us the sensitivity pattern. We say that as per the literature, as per the research, these are the antibiotics which could be susceptible. And also intrinsic resistant, there are some organisms which are basically resistant to some antibiotics, so these also are incorporated in the reports. Now, this is what I said in cascade reporting. That is, we keep on a hold on some antibiotics. If the narrow spectrum are sensitive, we hold the sensitivity of the broad spectrum antibiotics. Now, this is also antibiogram. Now, this is a very important part of any healthcare setup treatment plan. Once you know the antibiogram of a institution, of a healthcare institution, we decide on the empiric treatment. So this, and we can also develop a ICU specific antibiogram, which could help us to know what are the more prevalent organisms in our ICU, and also how to treat them or how to start them, how to start the treatment. That is the empiric treatment. Now, if we give the culture reports, we give the sensitivity, resistance pattern, but there is one parameter which has to be monitored at the for the patient. That is the PKPD parameter. That is pharmacokinetics and pharmacodynamics. Pharmacokinetics is what the body does to the drug, and pharmacodynamics is what the drug does to the body. So we have to do a therapeutic drug monitoring of antimicrobial agents in serum to ensure that sufficient antimicrobial concentrations are being achieved to reduce the risk of toxicity and prevent the emergence of drug resistance. And HPLC helps us to measure the drug concentration in levels in the serum. So why do we need to monitor the PKPD parameters? Because you see, in a critical illness, if it is a increased cardiac output state, there will be increased clearance and there will be decreased plasma concentration. If there is an altered fluid balance, then there is a decrease in the plasma concentration of the drug. No organ dysfunction, so normal plasma concentration. If there is a renal or hepatic dysfunction, then there is an increased plasma concentration. So you see, every patient or every individual in an ICU who is admitted has to be evaluated based on his comorbidities or his what is the state of his illness, and that determines which antibiotics, although they may be sensitive in vitro, they may not have the same effect in vivo. So this is one important parameter uh, which should be monitored in the ICU. Now, this continuous infusion is also recommended for broad spectrum beta-lactam and lactams and vancomycins in ICU patients. And what are the benefits of a continuous infusion? We see that if there is a continuous infusion over a period of 2 to 3 hours, there will be an improved clinical outcome, lesser antimicrobial consumption, and decreased mortality. Besides, the one component of the AMSP is a very important component is the IPC interventions, that is the infection prevention control interventions, which minimize infection spread. So these are the parameters which should be continuously monitored in the ICU: hand hygiene audit, care bundle audit, biomedical waste audit, monitoring of the environment cleaning, transmission-based precautions, and the MDRO surveillance. Now, what could we do in the ICU settings? That is, what could be the interventions in the in the ICUs to prevent the spread of antimicrobial resistance? One is formulary restriction and pre-authorization. That is, the reserved drugs could be restricted for prescription, and then this is something which requires a lot of work upon. It requires a lot of coordination, because in ICU, patient cannot wait for pre-authorization from a committee before they are given the reserved drugs. But then if this is implemented in a very coordinated way, then it could help prevent antimicrobial resistance. Prospective audit and feedback. Feedback and other AMS interventions like automatic stop orders, computer physician entry, and antimicrobial advice-driven interventions. And monitoring of AMS in ICU setting, Dr. Smruti will be elaborating on this. I would just touch upon them. Like, there are two indicators. One is outcome indicator, and the second one is a process indicator. If the outcome, under the outcome indicators, we have to determine the antimicrobial consumption indicators, like the defined daily dose, days of therapy, the mortality and morbidity indicators, microbiological outcome indicators, and the financial outcome indicators. In process indicators, we should audit the compliance with the institutional guidelines, prescription related process indicators, diagnostic stewardship with relation to clinicians, administrative correctness, structural indicators, infection control process indicators. I think I have exceeded my time. Uh, these are my references. Thank you all for your patient hearing. If there are any questions, Shireen, I would like, are you there?
Yes, madam. So as of now, we didn't get any questions. So we'll keep you updated on the questions, madam. The audiences are encouraged to put their questions in the chat box of the Zoom meeting. So thank you, Dr. Nipa, for that informative session.
Thank you.
Okay,
Shireen,
our
thank you.
next speaker is Dr. Smriti Lata Saho, who will present on monitoring of antimicrobial stewardship in ICU setting. Dr. Smriti Lata Saho is a consultant microbiologist and infection control officer at the Ashwini Groups of Hospital. She previously served as associate professor in the Department of Microbiology at Kalinga Institute of Medical Sciences, Bhubaneswar. Dr. Smriti brings both academic and clinical experiences in AMS implementation and monitoring in ICU setting. Dr. Smriti, over to you.
Okay, thank you for your nice introduction. And I will be speaking on the monitoring part. I'll share the screen. I'll share my PPT. Is my PPT visible?
Yes, madam, it's visible, madam.
Okay, thank you. Thank you, Nipa ma'am, for nicely explaining the antimicrobial stewardship in ICU. Actually, antimicrobial stewardship is very useful nowadays, as ma'am told that by 2050 we will have no antibiotic. The rate of multi-drug resistant organism, the prevalence is increasing in a very high rate. So we need to implement antimicrobial stewardship in ICU. So monitoring of antimicrobial stewardship in ICU setting is very crucial to ensure the rational antimicrobial use, reduce resistance, improve clinical outcome, and lower healthcare cost. So the question is how to monitor the thing is going in an appropriate way or not. So today I will present in this heading process indicators to monitor AMS, outcome indicators to monitor AMS, microbiological surveillance, AMS intervention audit, and education and training. First of all, process indicator. There are few process indicators that we have to monitor that. So, as ma'am told, antimicrobial stewardship is the right antibiotic for the right patient at the right time in the right dose, route, frequency, causing least harm to the patient and the future patient. So, it typically involves a multidisciplinary team. It involves the physician, involves the microbiologist, pharmacist, nurse, epidemiologist. So, it is a multidisciplinary action. So, process indicator, first we have to calculate what is the antibiotic prescribing rate per 1,000 patients. 1,000 patient days. So we have to from the electronically your system in the system you have to calculate the number of antibiotics. Suppose you want to calculate the ceftriaxone. So monthly ceftriaxone, how much it is using in the hospital and how many patient days in the hospital. So you have to calculate per 1,000 patient days the antibiotic prescribing rate. Then you can compare with in between your wards even with other hospital also, and compliance with the guidelines. You have to give the antibiotic policy to the hospital. So the physician, they are obeying that policy or not, that we have to monitor. Use of antibiogram to guide therapy, percentage of empirical versus targeted therapy, de-escalation rate, time to appropriate therapy, DOT monitoring, and daily review. We'll discuss one by one. So empirical versus target therapy. Empirical therapy, it is based on mainly three important elements. First, you have to diagnose what is the syndrome. The diagnosis is very important, and what is the common etiological agent in our locality. In your locality, maybe UTI, maybe you are getting UTI, maybe it is due to mainly catheterized patient, and maybe Klebsiella or Acinato. Also, you have to search which etiological agent is prevalent in your locality, and the local antibiogram pattern you have to follow. Then you will subsequently change to targeted therapy based on the AST report. So escalation versus de-escalation approach. Suppose E. coli sensitivity report is showing it is sensitive to colistin, tigecycline, carbapenem, PIT, cephrazone, sulbactam, amikacin, cefepime, ceftazidime, cotri, cipro, ceftriaxone. So there are two types of approach. One is escalation approach, another is de-escalation approach. If in your locality the local resistance pattern is unlikely, you are finding mostly the organism is sensitive to many antibiotics and patient is clinically stable, then you can start with a narrow spectrum antibiotic like ceftriaxone. But the AST report when comes, you are finding that it is resistant, then you will escalate it to meropenem. But when your local resistance pattern is very common and patient is critically ill, in that case you have to start with a higher drop meropenem. Then you are finding if AST report is a, it is susceptible to lower rank antibiotic, then you have to de-escalate the therapy. So this two approach is very very important to implement antimicrobial stewardship. So, role of hospital antibiogram is very important because it gives the overall profile of the susceptibility testing result of a specific microorganism to a battery of antimicrobial agent, and it guides the clinician in choosing the best antibiotic for that patient and detecting antimicrobial and monitoring trend in antimicrobial resistance within the hospital. So we have calculated from our culture report, and we have prepared our hospital antibiogram. It is given to the clinician. They follow this. So E. coli, Klebsiella, Citrobacter, Proteus, Pseudomonas, Acinetobacter. Usually we are finding these pathogens in our clinical samples, and we have calculated this percentage to many commonly used antibiotic meropenem, gentamicin, PIT, cotrimoxazole, levodoxy. So you can prepare it in your Excel also for your hospital. Every hospital, the antibiogram will be different, and that should be given to the clinician. For the gram negative bacteria, the one antibiogram, and for the gram positive bacteria, one antibiogram, it is given to the doctors. Then coming to duration of therapy. Duration of therapy is the total number of calendar days on which a patient receives at least one dose of specific antimicrobial, regardless of how many times it is administered per day. Suppose a patient is admitted in your hospital, and 10 patients are taking ceftriaxone 5 days each. So the days of therapy is 10 into 5, it is 50. So identify, so you have to, for the calculation of days of therapy, you have to identify the target antimicrobial, ceftriaxone or meropenem, and you have to collect the administration data from the pharmacy people or your EMR, then track the DOT, ideally using software, you have to track that, analyze the trend over time by department, in pulmonary medicine department, how much is using, in nephrology department, how much is using, that you can calculate. Intervene if duration exceed the recommended guideline. Suppose you find that in dialysis unit more of higher antibiotic they are using, so you can intervene there. Report and feedback to the prescriber regularly. So the best practice align with the standard treatment guideline, encourage shorter course where evidence support. If it is a community acquired pneumonia, you can give 5 days therapy. For urinary tract infection, you can give 7 days. So use DOT in quality improvement initiative. Always there is a benchmark for every antibiotic. There is a benchmark. So you have to calculate the DOT for 1,000 days, and you can calculate your DOT is above the benchmark or below. Then coming to importance of duty, it promotes appropriate antibiotic use, support de-escalation, and it also IV to oral switch decision you can take from the duty, helps reduce antimicrobial resistance, assist in performance benchmark, and useful in audit and feedback prescriber. Then daily review of antimicrobial therapy, that is the antibiotic timeout. It is very important because it is a structured approach within the antimicrobial stewardship program that prompts the prescriber to reassess. Suppose it is the time taken by the clinician. They pause and reassess the diagnosis is correct or not, the microbiological data is available or not, what is the response of the patient, what is the appropriateness of the current antibiotic. He can decide that whether de-escalation can be done, whether IV to oral can be switched, and if no longer antibiotic is needed, you can stop that. So it is the time. So there is a checklist. Usually we follow this checklist in our ICU. Culture report available or not, antibiotics spectrum appropriate or not. So it is individual for individual patient. This checklist has to be followed. uh, De-escalation is possible in this patient or not, IV to oral switch possible or not, duration plan documented or not. So this checklist, this is a short checklist that we can follow for each patient. That was process indicator, the antibiotic prescribing, how many antibiotic prescribing per 1,000 patient days, the DOT, and the daily antibiotic timeout. These are process indicator. Now coming to the outcome indicator. In the outcome indicator, we have to calculate antibiotic consumption, define daily dose per 1,000 patient days, rate of MDRO, what is the multi-drug resistant organism rate in our hospital, ICU mortality rate, we have to calculate, ICU length of stay, and readmission rate related to infection, and antibiotic cost saving. So, DDD, when we calculate defined daily dose, it is a standardized method developed by WHO to measure and compare antibiotic usage across hospitals. In wards, you can compare. In different region, you can also compare. DDD is the assumed average maintenance dose per day of an antibiotic for its main indication in adult. By the WHO, they have decided DDD. Suppose amoxiclav, it is 1 gram, and ciprofloxacin, it is 0.5 gram. So when we calculate our DDD, the formula is therapeutic dose. That is the number of tablet used into gram per tablet or vial divided by WHO defined DDD of that antibiotic. Suppose you are calculating for levofloxacin. Usually it is prescribed 750 milligram per oral daily for 7 days. WHO assigned DDD is 0.5 gram. So 0.75 into 7 days divided by 0.5. So it is 10.5. So by like that, we will calculate for different antibiotic and we can compare that with other. So it monitor high risk or broad spectrum antibiotic, particularly colistin. We have to measure that TDD, and we can compare between ICU general ward, the time period, pre and post intervention, and facilities for national regional benchmark is available. So we can compare our value with the benchmark. Then coming to rate of MDRO, it is very important. Multi-drug resistant organism. Usually we are finding that the rate of MRSA, VRE, carbapenem resistant enterobacteriaceae, the number is rising at a very high rate. So it refers to incidence or prevalence of infection caused by microorganisms that are resistant to multiple classes of antimicrobial agent. The rates are critical indicator in infection control and antimicrobial stewardship program, and the measurement, there is incidence rate we have to measure, the prevalence rate we have to measure, and device rate associated MDRO we have to measure. Incident rate is new MDRO cases per 1,000 patient days or per 1,000 patient admission. So we have to calculate what is the number of MRSA we are finding in 1,000 percentage, or VRE. We have to calculate that in for different MDRO. The prevalence rate is number of existing MDRO per 100% at a given point. At today, how many MRSA is present in our hospital? There is the prevalence rate, and the device associated MDRO, that is 100,000 catheter days, how many MDRO we are getting, or 1,000 ventilator days, how many MDRO we are getting. So common MDRO we find in our hospital, that is the MRSA, methicillin resistant staph aureus, vancomycin resistant enterococci, ESBL producing enterobacterus, and carbapenem resistant enterobacterus, multi-drug resistant Pseudomonas aeruginosa, Acinetobacter. These are the number is rising. So, high rate of MRSA 30 to 50% and ESBL up to 70% nowadays it is reported in tertiary care settings. Carbapenem resistance in Klebsiella pneumoniae, Acinetobacter often it exceeds 50%, and CRE and MDR Acinetobacter are increasing cause of healthcare associated infection. So importance is that this should be detected early, guide empirical antibiotic therapy, and support infection control intervention. So you have to isolate that patient. You have to decolonization. Suppose your OT staffs they come positive with MRSA colonizer. So you have to decolonize them by using mupirocin ointment. Evaluating antimicrobial stewardship outcome. Then ICU mortality rate. ICU mortality rate usually it vary depending on the geography, the patient population, the severity of illness, and healthcare resources. A large international cohort they reported average ICU mortality approximately 16.2% in developed setting, but in Africa or Middle East area or Ethiopia, the rate is usually 29 to 38%. So mortality rate again is very high in low socioeconomic status patient. So high. Next is microbiological surveillance. We discussed outcome indicator, then we discussed process indicator, then microbiological surveillance. Tracking the in microbiological surveillance pattern, ICU specific antibiogram we have to give. So antibiogram of the hospital you have to prepare, and antibiogram that is specific to ICU only. We have to prepare that, and culture positivity rate and time to culture reporting and initiation of appropriate therapy. That should be that data should we should take the data. So this is the antibiogram of our ICU. We differently we have to calculate it. The values are different from the antibiogram of the hospital. Then AMS intervention audit. That audit and feedback on the antibiotic use. Documentation of indication, dose, route, and duration. That we have to document. IV to oral conversion practice we have to document. Use of restricted antibiotic with justification form. So the justification form we are using restricted antibiotic uses, otherwise they may be misused. So there should be a justification form that to use restricted antibiotic. So continuous education and training is very important. Regular training session for the ICU physician, resident, nurses is very important. The infection, they are following the bundle care practice, the catheter care, the ventilator care, they are following or not, and they are isolating the multi-drug resistant organism or not. We have to check that. So regular training to the nurse and physician is very important. Then feedback meeting to discuss the AMS audit result. We have to discuss with the clinician, and we have to discuss the improvement area in which case we can improve that. This should be a interdisciplinary action. Then tools and documentation. There is some ICU specific AMS checklist are there, and electronic medical record alert for inappropriate use must be there. So whenever the antibiotic is misused or inappropriate, the use of antibiotic is inappropriate, there should be any alert. And antibiotic stewardship round involving microbiologist and pharmacist should be taken daily. So finally, to conclude, I want to tell AMS monitoring in ICU should be multidimensional, integrating the clinician, microbiological person, the pharmacological data, and regular analysis and feedback will definitely help and modify the practice, optimize the outcome, and curb the resistance. Thank you.
Thank you, Dr. Smriti. Thank you for those valuable insights. As of now, we have no other questions. Hello, am I audible? Yeah, thank you, Dr. Smriti.
Thank you.
Yes, ma'am. So our final speaker for today is Dr. Amit Raja Panigrahi, who will speak on challenges in implementing antimicrobial stewardship in ICU setting. Dr. Amit Panagri is an expert in critical care medicine, anesthesia, and pain management, and currently serves as the assistant professor of critical care medicine at Kalinga Institute of Medical Sciences, Bhubaneswar. With over 13 years of experience, his work spans critical care, pain services, palliative care, and medical teaching. Over to you, Dr. Amit.
Thank you, Afrin. Thank you for the introduction. And I wish to thank Nipa madam and Dr. Smriti Datta madam for inviting me for this program. Am I audible to you?
Yes, sir. It's audible.
Yeah, okay. So after learning all about this antimicrobial thing, I will try to put some light on what are the problems in the ICU. So doctors like me are end users or the beneficiaries along with patients of the antimicrobial stewardship program. This is usually led by microbiologists or ID physicians. So they start the program, but it's for us to implement it and make sure that all the proper protocols and the stewardship is put in the right place. So I'll tell you how there are things which prevent us from or make things a little bit challenging and difficult for us in implementing this antimicrobial stewardship in the ICU. So our agenda will be about understanding AMS, which we have already done. Then we'll understand the challenges in implementation, difficulties in execution, barriers to stewardship, and what strategies can we implement to overcome the challenges. So I think both the speakers have told us in detail about AMS, and the primary goal of AMS is choosing the right drug to prevent resistance, to reduce adverse effects, and ultimately the goal of every physician is to improve clinical outcomes. So this AMS helps us to improve our prescribing practice, helps us to choose the right appropriate therapy, minimize drug reactions while still maintaining efficacy of the drugs for the patient. So as we have already discussed, ICU is a place with heavy antibiotic usage. So the more antibiotics you use, the more the importance of antimicrobial stewardship. So if we have to choose the staff in the hospital that must be trained in antimicrobial stewardship, then we start with the ICU. Then gradually we have to involve every other department. Almost every other department that uses antibiotics must know about antimicrobial stewardship. But ICU is a place where it cannot be taken lightly at all. As we all know, one of the major problems in the ICU is the management of patient, which is already a complex thing. Now, our ICU patients do not come with one problem. They always have multiple problems attached to them. So here, antimicrobial strategies are very important to improve the infection management. And again, finally, patient outcomes depends on antimicrobial stewardship, because that is the main goal when we talk as doctors. Now, what are the challenges in implementation? First thing, as I said, most of our patients have multiple health issues. So they have, many patients have uncontrolled diabetes, or let's say organ failures like end stage liver disease, kidney disease. Many patients can come with advanced cancers. So these patients are already immunosuppressed. Many patients are on steroids. Some of them are on long-term steroids. Some of them have organ transplants. Some of them have implants, invasive lines, catheters, multiple breach of skin, and all these things. So all these things make the patient susceptible to infection by creating nidus for infection, as well as making the patient is already immunologically weak, and patients are unable to take the right amount of nutrition, so they do not have the energy to fight an infection, and they are in an area where they are surrounded with other people with severe infections, and they are surrounded with bugs who have been already exposed to multiple antibiotics, who are already there. Maybe some of us are already carriers of infections. So all these things make ICU patients complicated. Secondly, I work in a ICU which receives all types of patients. It's a mixed ICU. So many times we have, specialized ICUs, let's say cardiac ICU. So we do not expect a cardiac patient who comes with a MI or a arrhythmia to have an infection. Similarly, there are some neurosurgery ICUs. So these are single organ ICUs. So there the infection rates are expected to be low. But let's say we have a ICU like the one I'm working, it's a mixed ICU. So I receive patients who are medical patients, surgical patients, trauma patients, pregnant patients, elderly patients. So a variety of patients come to me, rheumatology, all kinds of patients, cancer patients. So when we have a variety of different patients, then there are multiple infections, multiple sources of sepsis, multiple drugs going on. Then there are different units involved. So making standardized protocols for such patients is very, very difficult, and even more difficult to apply effectively. And third thing is individualized assessment. Remember, every case in ICU is different, and and the patient's condition changes every few minutes. Patients are unstable, and their clinical condition keeps on changing. So it's important to have a very personalized assessment, and treatment strategies cannot be applied like one treatment strategy for all patients. So strategies have to be tailored. Now there is something they call precision based critical care, or precision based individualized ICU care. So every patient needs a special and different tailored management. So again, that is a problem, because although it is specific and precise, it also makes difficult for our AMS program to be implemented. Now third thing is rapid decision making in ICU. Patients are rapidly deteriorating in our ICU. Suddenly a patient, sometimes let me tell you one incident. Like 3 days back, we had a patient who had undergone radical nephrectomy. Now the patient was improving slowly, but patient was already sitting, talking to us. Suddenly patient had an aspiration. Patient went into septic shock secondary to aspiration. So in a patient who has gone into aspiration and septic shock, like in over a period of 5 to 10 minutes, Now, things can change rapidly, dramatically, in a matter of minutes at any time of the day. So such patients need quick decisions. So urgency in ICU decisions is a problem. And so in such patients, it is challenging to make a quick choice, rapidly changing an antibiotic, rapidly administering them in the said time frame. So here, following the AMS becomes difficult for a clinician. So even though it's difficult, we can still talk about ICU stewardship. So I believe every hospital needs to have an antibiotic or antimicrobial stewardship in general, where the principles more or less remains the same, but we can also have subspecialty antibiotic or antimicrobial stewardship for the ICU, for pediatrics, for surgery, surgical outcomes, or for areas like emergency. You know, these things can be implemented in discussion by making collaborative choices, collaborative meetings, so that more and more doctors, more and more team members can be accommodated into this AMS program. Then another thing is the diverse microbial spectra. So ICU usually has a very diverse pathogen. You can have a Klebsiella vap, and just beside that patient, you can have an enterococcal UTI. You can have a Candida auris patient. You can have an Aspergillus patient, a mucor patient. So there is a wide variety of microbial spectrum. Even now, after working in the ICU for 7-8 years, many times I see bugs that I have never heard of. Many species I have never heard of. So sometimes you start with an antibiotic, then the patients develop a hospital infection. Patient comes to us with a community infection, then they develop. So we start with one antibiotic. While the patient is getting better with that, patient develops a hospital-based infection. Then you start with like polymyxin-based therapy. Then you get an organism which is resistant to polymyxin, like Providencia, sometimes Bucholduria. Things keep changing. So there is a diversity of pathogens, and uh, infection management is also not easy here now, because things are so haphazard, things are so fast, things are so urgent. So here we always face a challenge in infection management. If you have like special cabins where patient numbers are few, patients are more or less stable, nurses have time to respond, nurses are more or less free, they have more energy to exhaust. There it is a little bit easy to implement our infection control measures. But when we have patients who are sick, where patients are rapidly deteriorating, patients are dying, we have some patients undergoing CPR, and suddenly patient going into respiratory arrest, someone needs an urgent dialysis, someone needs an urgent intubation. Here sometimes, even though doctors are aware of antibiotic stewardship, there is a little bit of difficulty in implementing, because you see a patient where his oxygen is rapidly going down. Then even though there is you may miss out implementing the right strategy. Sometimes you see a patient with a hyperkalemia who needs urgent dialysis. So it is sometimes possible that the junior doctor may be in a hurry inserted a dialysis line without adequate safety measures. So that does not mean we walk away from this stewardship. That means we need to make it more accessible, more oriented, more specific for that setting. So robust stewardship initiatives are still essential, because microbial threats are there 24/7 inside the ICU or elsewhere. So that we have to look into it. Then what are the difficulties in execution? One of the most common problem, or the problem where we need maximum investment, is resources and staffing. So there are abundant studies to prove that if we simply improving the nurse to patient ratio, then there is significant decrease in pneumonia rates, better execution of web bundle and all the bundles, and nurses can follow all the protocols and stewardship programs, and infection rates will go down. So nursing ratio, staffing, manpower is the number one thing. Second thing is resource allocation in terms of infrastructure, or appropriate cleaning, appropriate people to take care of the waste material, then timely interventions to deliver antibiotics. So these research constraints are the major problem that we face as far as AMS implementation is concerned. Not only the clinicians, it is the same for microbiologists, lab physicians also, ID physicians also. So if the hospital or the country or the nation's health plan does not allocate appropriate finances, appropriate revenue, appropriate infrastructure, manpower to stewardship, then all our talk about this program will not hold any good. So right resource, adequate manpower will have have a good impact on the stewardship, and sufficient personnel can make good consistency and improve the patient outcomes. After the manpower and resources have been taken care of, we have to utilize them by making sure they get the right education and the right training. We have continuously we see many new doctors are joining, new nurses are joining, new people are joining every day, every month, every year. We have new people coming and joining hospitals. So it is our duty to make sure they are trained before they get a hand on the job. So many hospitals, what they do is people just joining into the ICU, and later they are learning on the go. That is not acceptable. So just like all these cardiac arrest programs, people learning about basic emergency care, people must also know about antimicrobial stewardship. There should be some certification, some valid certification they should undergo before they can join and try their hand on patients, so that that knowledge can be put into preventing potential misuse. This can lead to effective treatment strategy and reduce resistance. So training programs are a must if we want our program to make a difference in the ground level. Another problem with us in the background is resistance to change. What I have seen is, especially the senior a doctor, the more resistance to change. So barriers to adoption of new technology, new information, new protocols, new way of managing infections, or new ways of identifying or de-escalation of antibiotics. This is something that should be adopted by all physicians. If a protocol is made, a stewardship program is made, it should be adopted right from top to bottom. So in fact, senior physicians should lead the way. They should adopt it so that junior doctors also can follow them. But many times there is skepticism to new guidelines. There are some physicians who might feel that they feel that their experienced wisdom does not go well with the new guidelines. That causes a bit of skepticism in them, and that can hinder the implementation. So effective change management strategies, effective communication, effective discussion, repeated audits, repeated discussion about new topics and how things are changing in different places can help us promote adoption of these stewardship programs. Now, what are the barriers to this implementation? There is a lack of standardized protocols in many hospitals in India and many developed many other countries as well. So that leads to variability in treatment decisions. If we do not have a protocol, different clinicians will make different decisions. Then that will lead to inconsistent patient outcomes. So importance of uniform guidelines. So today's healthcare is evidence-based care and protocolized care. The care should be protocolized, and people should be ready to follow a simple guideline, whether that is a ID physician, ICU physician, general medicine, surgeon, gynecologist. Everybody should be ready to follow the uniform guidelines of that hospital. Only standardized protocols can improve patient outcome and reduce discrepancies, reduce conflict in management among clinicians. So diagnostic tools are very, very important for us for implementation AMS. Empirical treatment are good to start, but we cannot simply rely and continue empirical treatment. So every hospital should invest time, money, and manpower in good labs, hire the right persons, hire the right machines, and get the good tools. So as a physician, ICU physician, I can say we have less time. People, we have a lot of pressure, to from the patient's condition, from their relatives, from other primary physicians. Everybody wants that 100% result, which is not possible. But there is a pressure to perform. So we need tools that are fast, tools that are rapid and that are accurate. Rapid and accurate diagnostic tools are necessary. When a test result, let's say a microbiological result, is delayed for a couple of days, then a non-infectious condition may be treated with antibiotics that are not necessary. So if some hospitals do not have adequate labs, so that leads to inappropriate prescribing, and that leads to more resistance. So it is very important that diagnostic tools are implemented right from the beginning of AMS tool in any hospital. Now, what are the strategies to overcome this? First thing is collaboration. It is very important that clinical physicians, surgeons, ICU physicians, microbiologists, ID physicians, pharmacists, nursing manpower, quality manpower, then all these people should be taken on board. It is very much important that everyone agrees on the protocol and guidelines. If a particular doctor is not happy or does not agree with the guideline, does not know about it, then he cannot be a part of the team, and that part of our hospital, that department will continue to suffer. Secondly, it is very common because we are different individuals, we have different thoughts, we have diverse perspectives. So this diverse perspectives and expertise should be taken into account, and that should be utilized before we develop any guideline or protocol. And the effectiveness of stewardship relies on integration of multiple disciplines, and only then that can improve the health outcomes. So we have all heard of how AI is changing things, how data analysis, newer technology is changing things everywhere, and healthcare is not left behind. We can use data and analytics as suggested by my previous speakers to monitor antibiotic usage, keep a track of antibiotic usage. So today data is considered is the gold. So we have to use this to monitor resistance patterns, and the ultimate knowledge that we get from all these analysis helps us to make informed decision making. And more data, more analysis helps in reforming or fine-tuning our stewardship efforts. It's not like a one thing or a one go. We have to keep using, repeatedly using the data to improve our stewardship measures. So continuous education. So as I said, training cannot be a once for all event. Many microbiologists and lab physicians dedicate like some time of their week in continuous ongoing education. Accountability is very, very important. Who writes the antibiotic? How long are they writing it? Whether the doctor writing the antibiotic is trained before with AMS or not, all these things are important. If accountability is not held, then patient safety is compromised. So education and training is important for patient safety, important for AMS. So the final conclusion is All the challenges in implementation include all the things we have discussed, especially the resource allocation and staff resistance. Approaches is like collaborative approach, and by enhancing antibiotic usage we can improve patient outcome. Now, before I stop my talk, I will just want to tell about a few patient. I was discussing about different uh, physicians from other departments, how we about the problems that they have. So, if we talk to neurology, uh, the problem is most of the patients with neurology come to us with altered sensorium. So So the problem with neurologists is they say, sir, our patient has a low sensorium. Patient can aspirate anytime. So mouth care is not good from the nurses. So we want to give an antibiotic. So here, let's say patient comes with a stroke. The patient does not actually need an antibiotic, but here they want to give a prophylactic antibiotic. So if we can convince them that by providing proper oral care, by providing aspiration prophylaxis, by providing like backup, all these things, we can actually reduce the infection, and we can take them on board. We can do a clinical audit, then we can convince them to reduce this thing. Second thing, let's say we get a patient with meningitis. Sometimes it is very difficult to differentiate whether it's a viral meningitis or a bacterial meningitis. In that case, doctors prescribe both antibacterials and antivirals. So if we have advanced diagnostics, where we have all this now biofire and other profiles where you can rule out infections, then we can limit the antibiotics. Now, coming to nephrology patients are, CKD patients. Let's say CKD patients. CKD patients, we have an issue with management of these dialysis lines. These people are already immunosuppressed. They will have dialysis lines, and these lines, if not taken care of, become a source of infection. Then most of the CKD patients, they're finding the right dose of antibiotic is a challenge. Even now, we do not know what is the exact antibiotic that should be used in a patient in ICU or in the OPD or in the IPD. So even nephrologists or even ICU physicians, many times it's a guessing game. We have to just guess the dose, and based on response, we have to titrate the dose. Similarly, for AKI, we do not know what is the exact dose of antibiotic that we should use in patients with AKI. So we need a lot of research in this subject to use the right antibiotic. As madam said, we need monitoring of drug levels. Many hospitals do not have this facility. It is an expensive facility, but if we can implement this, that can significantly reduce our antibiotic exposure, reduce the adverse effect. Now, coming to patients of cardiology. So many patients of cardiology will come with cardiology patients will come with heart failure. Now, in a patient with heart failure, if you look at the X-ray, it is very similar to a pneumonia. It is very difficult simply on clinical basis or even on imaging or a chest X-ray to tell whether the patient has a heart failure or the patient has a bilateral pneumonia. So in these cases, many cardiologists, many ICU physicians prefer to put a antibiotic. So here we need, specific protocols, specific things like using a procalcitonin or using some sepsis markers to identify, or maybe many times we use anti-pro-BNP or other, markers where we can clearly identify a heart failure from a LRTI. If you can do that, we can reduce an infection. So investing in diagnostics which not only diagnose an sepsis but also diagnose other things which are not actually sepsis. So if we can prove a disease is not actually sepsis, then also we are reducing the antibiotics. Now let's say pulmonology problems. Patients who come with COPD and asthma, we know many patients coming with acute exacerbation of COPD are actually viral illnesses, but patients are usually started on an antibiotic for community acquired pneumonia. So 70 to 80% of these infections are viral infection. So again, if we can have a respiratory panel kind of thing, which is now available, but this is a very expensive test. If we can have such tests which are low cost, fast, and which are available in most hospitals, then we can reduce the antibiotic exposure. Now coming to gastro problems, let's say acute pancreatitis. Pancreatitis patients come with fever, they will come with tachypnea, they will have high TLC counts, high CRP, high procal levels. So it is impossible to differentiate pancreatitis for sepsis because they will have the same features. It is very, very difficult. So even though we are aware that in the first week of illness, there is no role of antibiotics in acute pancreatitis. All physicians are aware of it. All gastroenterologists are aware of it, but nobody has the guts or the courage not to write an antibiotic. If I don't write an antibiotic, someone else will write an antibiotic. The issue is here again, we need very specific, very sensitive sepsis markers. As we all know, sepsis is an ongoing research thing. The definition of sepsis infection, sepsis keeps on changing. There is a lot of unmet research, and we do not exactly know what exactly is the trigger for sepsis. There is no gold standard test to diagnose a case of sepsis. So such patients are difficult to be differentiated from non-infectious sepsis things. So here again, antibiotics are misused, but again, clinicians cannot do much here. Let's say someone with a CLD, a chronic liver disease patient coming with hepatic NCAF. So here patients might be treated as meningitis. So focused treatment is essential, and we need very specific markers to differentiate an infection from a non-infection. Elderly patients. Now, geriatric patients, most of the time present with very atypical signs and symptoms of sepsis. They may not have a fever. They may have a normal, TLC count, but they may have an infection. So such patients, we tend to actually overtreat. So again, here we do not know what exactly needs to be done. Many post-surgical patients. Now, we know that patients who are undergoing elective surgery do not need more than 1 day of antibiotic therapy. But here again, the surgeons are scared that if something goes wrong, they might have to reoperate. And no surgeon wants to take their patient to OT twice. So this is where they want to overtreat. So here it is very essential that we take them in the loop and build their confidence, and that infection is something that cannot be, many times surgical infections, they think that can simply be treated with antibiotic. So we have to understand that if it's a surgical cause, then the source correction can only improve with a surgical correction. So these are the problems that we face with physicians on a day-to-day basis, and these are significant challenges that we face. That's all. Thank you.
Yes, Dr. Amit, you told the right thing that in pulmonary medicine case and neurological patient,
Yeah.
most of the time they have to over treat the patient,
Yeah.
mainly for meningitis or in pulmonary medicine.
Yeah.
But respiratory panel and meningitis panel,
Yes.
they can give a result within 30 minutes, and it is
Yeah,
also
yes, I am
available.
aware of it, but the problem is those panels are very costly. I don't think hardly
Costly,
5 to
but
10
it is
percent.
approved. It can be approved by your PMJY or BSQI person. It is
I
approved
don't
now.
think so. I don't think till now it is not approved here. So
Acha.
most of the hospital failed. I would be very happy to use it, on a
It
day-to-day
is very
basis.
useful.
It
Yes.
is very useful. It reduces our antibiotic exposure. And I can, nowadays nobody is interested in clinical decision. If I tell a patient's relative or a clinician that I don't feel there is an infection, they will not believe me. But if I show them a report, if I show them a panel report or some report, look, I have done a test and the test does not show an infection, only then they will believe me. So although in the
For
developed
insurance
countries,
patient, you can do.
yes,
Insurance
yes.
patient,
So
you can
wherever
do that.
feasible, we do it. So if
Mhm.
feasible, we do it right away. But
Mhm.
many times we cannot do it, mainly because, as I said, due to financial constraints. But I'm hopeful as our economy is developing, we
Mhm.
will get access to it more easily with less cost, and more people can get the benefit of all these latest diagnostics. Like ma'am has said, multitox and other things can give faster results that will significantly reduce our antibiotic exposure. Thank
Yes,
you again.
another question I want to ask, that can you give your experience where you have done de-escalation and patient has improved?
Yeah, that's uh, now look, most of the critical care physicians now, for them, AMS training is a must. It is compulsory. So I would say many of the times, like let's say antibiotics like linezolid or antibiotics like levofloxacin, we tend to use oral over IV nowadays. Number one, it reduces our cost easily, and second thing, many times it happens that patient comes with some infection. We start on meropenem, then we get get the result, and the antibiotic is and the bug is sensitive to a lower antibiotic. Then we go back to a lower antibiotic. That is not a problem at all, as long as we have a you know culture report or some evidence that the
Mhm.
ongoing infection can be managed with something more specific, narrow spectrum, lower cost, with a lower this thing, and then that is not a problem at all. I have seen many times patients have been started on meropenem, we diagnose a meningitis, we go back to ceftriaxone. That's not a problem at all. Many times, every day, like for severe patients, I will stop antibiotics and I'll see whether patients are responding or not. All these hepatic encaph patients, if I'm sure that it is a case of hepatic encephalopathy only, then we stop the antibiotics. After a couple of encephalopathy therapies, patient wakes up. Once the patient is waking up, even their physician think, okay, patient is waking up and this fellow is stopping my antibiotic. That's not a problem. So we face resistance, okay, but we have to take them in the loop. Sometimes we use procalcitonin many a times, like after 5 days of therapy or 7 days of therapy, we do a procalcitonin on ICU arrival. Then after a couple of days, we do it, repeat it again, and then if it is falling, and as per the algorithm, if the levels are low or more than 80% has come down, we can stop an antibiotic. That's not a problem. But many times we use clinical acumen also. If the patient has responded beautifully, patient is doing well, and I feel, or I take another, if I have a doubt, I ask one of my colleagues, do you feel the same, can we reduce the antibiotic? If he or she also feels the same, then we get more confidence that okay, now we can reduce this thing. So sometimes we talk to microbiologists. Many a times we talk to microbiologists. We have a microbiologist group where we put questions also, that ma'am, the patient is so and so, I think this can be done, what do you think? So if two or three doctors feel there is no doubt about a particular thing, then we can de-escalate the antibiotic, not a problem. Many times patients with TB and other infections, they come in a weird symptom complex. So they are put on multiple drugs. Once you make an accurate diagnosis, it makes no sense to continue other drugs. We simply stop other drugs. Okay, so many times we see this intestinal obstruction, patients with TB coming with intestinal obstruction. Now they are started with something else. Now, after a couple of days, we diagnosed them as TB. So we stopped the antibiotics, start them simply on 80 days. So nowadays, starting an antibiotic does not need a lot of knowledge. Stopping an antibiotic needs guts, needs courage, needs that wisdom or the knowledge. So it's difficult, but okay, we are working on it. We are trying to take more and more in the loop. Hopefully, we'll improve in this front.
Yes. Thank you.
Thank you, Afrin. Thank you, Nipa ma'am.
Thank you, sir. There is another question. Sir?
Yes, please go ahead.
Yes, sir. Dr. Sarka has asked a question that when the patient is getting into the ICU in septic condition with already a course of antibiotic prior, you screen a patient newly admitted and send specimens to microbiology. Unfortunately, most of the time we get no growth results the patient. So how it will be managed?
Yes, this is a pertinent point raised by Dr. Sarka. Look, we have to understand that patients who are coming to ICU or patients who have sepsis, even with the best possible diagnostics, even with the best possible manpower, even with the best possible protocols, only 30 to 50% patients will have a positive culture. Okay. The problem here is many a times patients are given antibiotics in the emergency. Sometimes patients take antibiotics in the OPD basis. Sometimes patients have already received antibiotics by the time they come to the hospital. Even if they have not received antibiotics, patients, uh, you know, um, are so sick that we have to give them antibiotics as a priority. So 30 to 50% patients will only have a positive culture. So that is again a hindrance from stopping an antibiotic. So as I said, sepsis is an ongoing research. So till we get more and more sensitive markers, we have to use our clinical acumen. So if you are starting an antibiotic for a patient who is sick, patient who is septic, patient who is going to the ICU, that is not a problem. Starting an antibiotic when you think it is needed or when you have a doubt, then that is not a problem. But the problem is accurately assessing when to stop the antibiotic. You cannot use an antibiotic. Okay, I have started it, I'll use it for 10 days. You need to have antibiotic timeouts. You need to have a protocol or a goal or a plan to de-escalate the antibiotic. I must be very clear in my mind when I start an antibiotic that when I will stop the antibiotic. So if I'm not getting a culture report, I must be sure in my mind that okay, after the patient's condition gets better to this level, I will stop the antibiotic. Or if I will use a particular marker, if that marker is within a particular level, then I'll stop the antibiotic. Or if the patient's clinical condition improves to this level, then I'll stop the antibiotic. So we need to have this antibiotic checkouts, antibiotic timeouts. So even if we do not get an infection, the infection may be there. So we have to enforce antibiotic protocols, AMS protocols right at the emergency also. So we have to train our emergency staff that if you plan to send give an antibiotic, please collect a culture before giving the antibiotic. So these things have to be implemented right away. And not only that, we need strong policies from the government, from the administration, that pharmacies should be restricted from selling any antibiotics to patients without any proper prescription. So in many parts of India, you can buy an antibiotic without a prescription. That is a problem. If you go to developed countries, I have worked in the UK as well. So my son had a fever when I was in UK. My son had a fever, and being a doctor also, I was just checking if I could get an antibiotic. I could not get an antibiotic. So you need a prescription. So if there is an emergency, you can go to the hospital. The hospital doctor will decide. So pharmacists or patients themselves should not be going for self-treatment, self-cure. That is a problem. But we should also accept that this is a fact that we will miss some growth, we will miss some infections. There we have to have the clinical acumen to judge. I hope that answers the question of Dr. Sarka.
Yes, sir. Thank you so much for the briefing, sir. And I can see a lot of comments appreciating the speakers here in the chat box. Thank you, all the doctors, Dr. Nipa, Dr. Smriti, and Dr. Amit, sir, for this insightful session. We truly appreciate your time and valuable contribution today. Thank you, doctors.
Thank you. Thank you, Afrin.
Thank you, Afrin and Dr. Amit and Dr. Smriti Lata. Just
Thank
at
you,
the
ma'am.
end, I would like to say that I think the culture of giving antibiotics and why we should give antibiotics, there's also a pressure from the patient that you see, even if it is in the OPD, he may have come with osteoarthritis, but most of the patient, if you don't write an antibiotic, maybe the culture has changed now, I don't know. But it was like if a doctor doesn't write an antibiotic, he is as if he is not paying attention to the patient's complaints. It is as if he is writing an antibiotic would cure him of osteoarthritis also. That's what I mean. The pressure from the patient point of view is also there. So maybe some of the doctors are also catering to that pressure.
Yes,
I
ma'am, you are
would,
true.
Ma'am,
yeah.
I will share an experience that I had like 1 to 2 hours back. Right now, I have a duty in the ICU. I am in the ICU. Okay,
Yes.
so I have just
Yeah.
taken permission from my senior that I have to attend this meeting. Please grant me like 1 to 2 hours of privacy. So I was told by one of my surgeons that there is a patient in the emergency who has been patient was shifted from Smriti Lata's hospital, Aswini hospital has been referred to here. Patient is a case of cholecystitis, cholelithiasis, which was not taken care of. It has led to cholecystitis. Now it has become acute pancreatitis. So patient has come with low-grade fever, abdominal pain, but patient is stable. Patient can be managed in the ward. So the family is a high-profile family. The patient's husband is a additional secretariat. He is a senior OS officer. So I saw the patient. I just prescribed something. So the patient has infection, patient has acute cholecystitis and cholangitis going on. So that must be treated. I understand an antibiotic is essential for this patient. Patient has already received some antibiotics somewhere else. So patient's relative is a pharmacist or something else. So they were talking with the relative and the relative was telling them that why don't you give meropenem? So patient who himself is a non-medico came and told me, sir, why don't you give meropenem? So I said, you don't need a meropenem in this patient. Patient is stable. Patient has been started on a drug that covers adequate organisms. So patient's husband was not happy. So in the meanwhile, the surgeon comes and he listens to him and he says, no, it's okay. We don't need higher antibiotics. Patient is more or less stable. We can manage her in the ward. And after like we talk to him for 5 to 10 minutes just not to give a particular thing. Okay, so sometimes if the it becomes
more
difficult,
of a, it's more of a social problem,
Yes.
as well as one more thing is I don't think we are oriented in our medical education towards this AMSP.
Yes.
So that emphasis is not there. We know
Yeah.
how in all throughout, in pharmacology also, in microbiology, or maybe some portion we would have mentioned during that chapter on infection control, a small 2 slides on AMSP. So you see, the problem has become so large. I don't know, when we grow old, we would be there would be no antibiotics.
Yes, that's entirely
So
possible.
with that emphasis, I mean, the problem is so huge, but it does not get its due attention.
Yes.
That is why. I mean, it's more of a social problem now. It's become a public health problem, of course. And also this antibiotic prescribing, if you don't prescribe, patient is not happy. So you see, practitioners, to make the patient happy, they also prescribe. So social public health problem, and so, and that awareness problem. So maybe we are still, like you said, you were in UK, you didn't get any antibiotics, being a doctor also.
Ma'am, in
So
the
that
UK,
amount
like we have
of
managed
stringency.
80% of the patients they will manage with simply augmentin, and rarely they will use gentamicin, one or two drugs. If I mean majority they have done that. I think they have like focused really really hard on that. But here it has become very difficult now. Let's see, with more and more awareness coming, I hope we can control
You have to
this.
search for alternatives to antibiotics, bacteriophage therapy,
Yes,
something like that. Other alternatives, I don't think we could go on with this antibiotic thing.
yes,
Okay,
madam.
thank you, Dr. Amit and Dr. Smriti Lata and Afreen, for giving us a platform to express our views. Uh, Thanks a
Thank
lot.
you, ma'am. Thank you, ma'am. And
In chat
sorry,
box, there
madam,
is a
there
question.
is another question for Dr. Smriti. Um, Madam?
In chat box, there is a question.
Yes, ma'am.
Should
Should
we
we have to do monitoring indicators for AMSP different from different departments?
Yes, we have to monitor for different department, for pulmonary medicine, for dialysis unit, for neurological main unit, in those patients where ICU is required. Because by doing that, you can trace the problem area. Suppose in dialysis unit you are finding that majority of restricted antibiotic are using, so you can see you can contact with the clinician, and take the precaution to prevent that. So you have to monitor different indicators that I told. You have to monitor the days of therapy, the antibiotic prescribing rate per monthly. You have to track that, and then you can know, and the justification, that restricted antibiotic, the justification form, that you have to track. You have to track for different department differently, for ICU, for neurological patient, for trauma patient, and for surgical patient. Suppose elective surgery they are doing, then and the need of antibiotic is much less, but for trauma patient where the need of antibiotic is much more, so you have to monitor for different department. I think uh, Dr. Asavari, I told your answer.
Yes, madam. Thank you, madam, for briefing us. And a lot of appreciation is being recorded here in the chat box where you can find. Thank you so much for all of the speakers and all of the audiences. So thank you so much, doctors.
Should we leave?
Yes, madam. Yes, madam.
I
Thank you.
think it's time to
Okay,
end the
Thank you,
thanks.
meeting
sir.
now.
Thank you, madam.
Thank you, ma'am.
Okay, thank you, Afrin. Bye.
Thank you, madam.